Okay, I might just start so that you can have a break before the next one, because I don't think this will take too long. So I'm doing dementia, delirium, and cognition, but really it'll mostly just be dementia and delirium. They're pretty much your bread and butter, like psych conditions. So hopefully this will be like a bit of a like a revision. How many of you have done psych or are on psych? Okay, yeah. Anyway, so we'll just start off with the case. So you're an intern on the rehab ward and you're doing an admission for Miss L, this 74-year-old female who's been transferred from the surgical unit 2 weeks post neck of femur fracture. She's happy to see you and comments on your funny R.M. Williams boots as you introduce yourself. As you inquire after her past medical history, she mentions that she wishes to return home, would like to catch the plane there despite living in Melbourne. Halfway through your consult, she answers a friend's call and passes you the phone to say hi. Her friend sounds exasperated and tells you that over the last couple of days she has received a number of strange calls from Miss L, sometimes coherent and sometimes just bizarre. So maybe think about what this, how did that, oh no, is there a way to do that? To just get like me to have presenter view and everyone else not to see it? Oh, that's okay. All right, so what do you think? Like, does everyone have an idea about what this might be? So I would think about, like, first off, what it is, and then if you know what it is, think about like what you would do to treat it and what might be the cause of it and what risk factors this woman has. And I'm just going to get my laptop. So does someone want to yell out what it is? Yeah, delirium. Good. All right, so delirium. And this is actually like, I was on my aged care rotation at the start of this year, and this was like pretty much exactly the consultation that I had with one of the ladies. She was really cute. So yeah, so it's a fluctuation in, so these are the criteria. I don't think, personally, I think the best way to learn conditions, it's good to have the criteria and know what they are, but you also, I think it's more intuitive when you try to think about like what conditions are. You don't need these exactly to figure out if someone has delirium, because it's quite easy to have a gauge of what delirium would look like anyway. So it's a fluctuation in that it fluctuates over the course of the day and also from day to day. It's a change from their baseline and it's acute. They have an impairment in attention or awareness, so that'll mean that they often can't follow conversations or focus on anything that you're saying. And it's usually less than 1 week, but the consequences of delirium last for months, and it can be like a predisposing factor to getting other conditions like dementia. So it has really bad outcomes and you need to try and recognise it early if you can. And then they have like one other area that they are struggling in. So with this lady, it might have been disorientation. She doesn't know where she is and she doesn't like understand how to get home. And then there's no other underlying pathology. So that just means that like there's no other like she doesn't have schizophrenia that might be causing these delusions. And there's always a physiological cause, except that sometimes you won't be able to find it on your examinations. Yeah, so aspects can be things like she's post-fall, she's been transferred, so she's in a new and unfamiliar place. She is making sort of like funny comments and interrupting you. She's talking about like, yeah, disorientation, last couple of days. So it's been going on for a couple of days and she's telling you that they're strange, which means that this lady isn't at her baseline. And sometimes she's coherent and sometimes she's bizarre. So that's talking about the fluctuation in mental state. Yeah, she's distractible, which is why she keeps like mentioning things that she shouldn't. So there's different types. Some other like presentations that you could get would be like someone just lying in bed, not responsive, rambling, because the hypoactive form of delirium presents like that, but you're unlikely to, in a Monash question, you'll probably get a hyperactive because it's more pronounced, it's more like unique in the way that it presents. I don't know if I'm allowed to say this, but last year one of our OSCEs was on delirium, and it was like a hyperactive form. So not many causes for visual hallucinations. Delirium, psychosis, and Lewy body dementia with Lewy body, although we don't like major neurovascular neurocognitive decline with Lewy bodies. And they'll be running around. So if you have a patient who's like running around the ward, that might also be an indication that they have dementia. Okay. So often one of the ways that you can differentiate the visual hallucinations in terms of like Lewy body dementia or delirium will be that Lewy body will be quite pleasant, whereas in delirium often they'll be like quite distressing hallucinations. They have really poor outcomes, like I said. And the way that I think about delirium is we all have like a baseline cognitive reserve, like this cognitive reserve. And so you have to consider when you're thinking about how to manage it or like how to prevent it, which is the best case scenario, you should think about who's at high risk and how bad is the injury that they're going to receive. Because if those two are really high, then you should try and like be very aggressive in your prevention. And if it's like a young person that is having like a minor operation, it won't be a big deal. But if it's a young person's having a really serious operation, they can still get delirium. So risk factors and causes sort of tie into each other, but most of the risk factors actually have to do with the cognitive reserve not being there. So if you're doing this, you probably wouldn't be doing this in OSCE, but if you were, you could just try and think about like what are things that might make you have a lower cognitive reserve. So previous deliriums, being in a nursing home because it's likely that they're already struggling with their assisted daily living activities in a nursing home. Old age, polypharmacy because you're sort of like already insulting the brain a bit. If they're quite unwell or substance affected. And then random ones like male visual impairment because that contributes to disorientation. And then if they've had any recent surgery. So there are a couple of acronyms that you can use to remember causes. So I think like this one is probably, I find this one better because I think it spells it out more. But the important thing, which unfortunately isn't at the top, is drugs. So drugs are like one of the most common causes. So things like opioids, steroids, any anticholinergic medication are all like really high yield, but really like any medication really is always like a risk factor. So and then like your antidepressants can cause electrolyte issues. Endocrine issues would be like thyroid, glucose, Cushing's disease, infection. So that's common in like Monash questions. So it'd be like if they had a cough and they have pneumonia and they've got a chest infection, so you need to do a chest x-ray. They could have encephalitis, even like wounds. Stroke and epilepsy are self-explanatory. Nutrition, so thiamine and B12 are two big vitamin deficiencies that they might have, which could be masquerading as delirium, but it's not actually. What else? Other, so that's like your environmental things. So glasses, hearing aids, if they're disoriented, it's going to increase their risk of getting delirium. And then metabolic, so their electrolytes, abdomen, so if they've got constipation, they're more likely, if they have urinary retention or UTIs, they're more likely to get it. So there's this thing called a CAM score, which is essentially just 4 criteria. So it pretty much summarises the DSM criteria. But acute onset and fluctuating course, so the symptoms will go up and down during the day, and like it's not just down, it's not like fluctuating, but it's just down. It's just like they'll come and go. So they'll inattention, so they'll often have trouble doing it. They won't be able to do an MMSE in most cases. So even if you ask them to count back from 10, and they're usually very literate, they won't be able to do that. Disorganized thinking is just like irrelevant ramblings. And like altered state of conscious will be if they're like hyper alert or if they're like sleeping more than they should. So examination investigation. So you want to do heart, because cardiac congestive failure can cause delirium, as well as any causes of like hypoperfusion, which obviously, yeah. So just do your cardio. You can do like a brief cardio exam, listen to their lungs for any like crackles or atelectasis, especially if they've been in surgery. Wound sites that might be infected, dehydration, constipation, pain, any like IV catheter or IVC. So essentially the investigations are just trying to address the potential causes, and what you need to do is try to tailor it to the person that you're seeing. So if you know they've been for surgery, then, and you know that they have like some renal impairment, you would like highlight your UECs. And then you can consider doing these things. The CT head you would do if they had like neurological symptoms that were indicative of that potentially. So that might be like focal symptoms, any neurological focal symptoms. If they had anticoagulant use and they've had a head strike, any gait changes, or if they have a cancer history because like there's potential for meds. Yeah, so the best thing that you can do is try to prevent it, because there's not too much that you can do to treat it, to be honest. And then you have to treat the underlying cause. So that'll just depend on what it is. Address the modifiable risk factors. Even if you find the cause and can treat it, you should still try and like move them to a bay close to the nursing station. Make sure that they have like familiar faces, some orientation. If you can get like their night and day cycle back, that usually helps. And that might be things like decreasing their OBS if that's possible, or not giving them medications at 10 p.m. if they go to bed at 8 p.m. Like try to shift that around if you can. You can give them earplugs. Yeah, and then try not to physically restrain them. Yeah, so that's that. And then you can lower their bed, just so that if they are going to get up and like go around, at least they're not going to fall out of bed. And then the pharmacological, you shouldn't, like ideally you really just shouldn't be using any antipsychotics in old patients anyway, unless they have like a psychosis of some form. But the first line is haloperidol, which you wouldn't give in dementia with Lewy bodies, because they already have like a dopamine deficiency, and then you're like worsening their dopamine deficiency. And try not to use benzos, because it can cause they can get more confused when they come out of it. But I think lorazepam is written on like the AMH side. Yeah, which you might use in dementia with Lewy bodies, but you would just try to avoid using. Good. Okay, so dementia overview. So it's a acute fluctuating state. It has poor prognosis. I think something like 50% of people start to develop, I'm not sure if that's right, but there was a large percentage of people tend to develop dementia in the first year after they had their first delirious episode. And the effects of it actually, like people say it's acute, but people will be confused for like months sometimes. Like they won't return to their baseline straight away. Yeah, cool. So I think we talked about this. All right. So we're doing major neurocognitive disorder. So essentially this is dementia, and the DSM has split it into minor and major. I'm just going to look at major. So you have like an insidious onset of decline in more than one of the cognitive domains, and it interferes with their independence. Can't be explained by something else, so they can't have like any sort of other psych condition, and it's not happening in the presence of delirium. And typically, I think there's been a move away from like cutoff scores and like how they compare to the rest of the cohort, because people have various levels of like that cognitive reserve, I suppose, which also applies to dementia. So instead of looking at it from like a standard deviation point of view, which apparently it's typically like 2 standard deviations below the median for like cognitive testing would be dementia. But now they've sort of like moved to like how they function as opposed to how they used to function. So the 6 domains you can look at. There's like complex attention. So that could be if someone is having a conversation with someone but their TV is on and they're having a lot of difficulty concentrating because they're having difficulty with multiple stimuli. And they also have trouble retaining like old information and new information. Executive function, so they'll have difficulty struggling trying to plan new tasks. They might require other people to plan them for them. So, and sometimes this manifests as like difficulty in work. They'll have difficulty making decisions at work and they'll find that they're declining. Learning and memory, so sometimes people will be like, I go to the shops and then I forget all the things that I was going to buy, or I've forgotten my keys at home or my purse. And they might need prompting at the start to sort of remember that, or they might forget like they were going to catch up with someone or that they had appointments. Language, yeah, they'll use, actually people with dementia are very good at like talking around what they're trying to say. So sometimes they cover up very well the fact that they have a deficit because they'll talk around the word that they're trying to say. So you wonder if they're just like a bit like vague or if they actually like don't know the words. Cool. So, and then like perceptual, sometimes this will manifest in early stages as like difficulty with driving. So they'll be having small crashes or they'll be coming home with dents in the car. Risk factors, so old age like you, sometimes genetics plays a role, particularly in like Down syndrome. The reason that Down syndrome is a risk factor, it's a risk factor for Alzheimer's disease because I think the chromosome 21 is the one that does the amyloid plaque, creates the amyloid protein that then deposits in the brain. And so there's like too much of it being made. And then for vascular dementia is like cardiovascular disease and factors. So staging, mild is you can still function independently. You'll have little lapses sometimes, and sometimes it's mistaken for normal aging. It usually lasts for 2 to 3 years. They might have things, yeah, like organisation difficulties or difficulties at work, and that'll be what picks it up. Moderate is when you have trouble performing like everyday tasks. Your memory will be getting worse, so you might, people, you know that story about like someone will go for a drive and then they'll forget where their home is. Like that's moderate sort of stage, and but they shouldn't be driving that stage. They might go for a walk. Yeah, so you need to prompt them to be like, you should have a shower, like let's go. Or like eating and other activities. It can last 2 to 10 years, which is quite a long time. And there can be this like commencement of what are called BPSD symptoms, which are like your behavioural and psychological symptoms that are associated with dementia. So they can like start to get a bit aggressive. They might not be sleeping well, and they might get a bit like paranoid. You often need to supervise people at this stage. And this is where they need full-time care in like a dementia ward. They'll often have difficulty. They can't. They'll start to have like functional problems. So they might not be able to walk. They might be incontinent. Sometimes they need like they'll need people to just do everything for them. All right. Mrs. T has a 70-year-old female who's presented with her daughter who expresses concern that she seems to be struggling at her volunteer work over the last few months. She has been making small mistakes, forgetting to order equipment and misplacing objects. Her daughter also mentioned that over the last year, her mother has had multiple unpaid bills. So if you want to yell out, but never worked very well in my year, so I'm just going to go to the next slide. So this is typical of Alzheimer's, which always starts off with short-term memory loss, and then it will proceed over the course of the disease to long-term memories, which is quite interesting because they'll start off not remembering like what they did yesterday, and then by the end of their disease, they can sometimes be living in like their 20s or be asking like where their mother is. Yeah, so the patho is that you get degeneration of the cholinergic neurons. And it causes like less ACTH, which is acetylcholinesterase, which is why the cholinesterase inhibitors work really well. It atrophies the hippocampus, which is why you get short-term memory loss. And interestingly, like later the amygdala is affected, which means that even if they don't remember someone or something, they can still have emotions attached to that person or thing. And then like just know that it's like beta amyloid plaques and tau protein. On MRI, you'll see cortical atrophy, indented sulci, and enlarged ventricles. So essentially the brain is just atrophying, and that's why. And there are, like in the CSF, they're finding like that there's low amyloid and high tau proteins. But on one hand, like they don't do that routinely, and on the second, it doesn't really matter because there's nothing, you can't do much to modify dementia. So, yeah, so it's an insidious onset. It starts with like declarative episodic memory, which means that they might not remember like something that has happened at a certain place and time in the recent past. The family will often describe them as less motivated or less organised. And on an MMSE, that this might present as with the delayed recall, so they can repeat it straight away, but they can't repeat it in like a few minutes, which is fine. REM sleep in like dementia is more associated with Lewy body disease, like disturbance in REM sleep cycle, but it's also a very early sign of Alzheimer's disease, so it will often be like the prodrome, like as it's coming along. And then in the early stages, it'll be like executive function and then visual, and then they'll have some language and then behavioural, and in the late stages, that's where like the functional and the memory and the ability to do like normal things will be impaired. All right. Oh yeah, and early onset is less than 65. It usually presents differently to the rest, difficulty at work and yeah. So she's struggling in her volunteer work. Yeah, it's a fairly typical pattern of what you would think like typical dementia looks like. They can withdraw socially, so maybe they'll stop in a question. It might be like they've stopped going to their social event, or like there's been some conflict in the family because she keeps leaving the keys somewhere. And they can believe that items are being stolen when they're not. And there's also this like misidentification. So at the end stage of dementia, people will like look in a mirror and not be able to recognise the person that they're looking at as themselves because they don't see themselves in the way. Just that's it. Cool. So I don't know if this was just gone over, but just quickly. Acetylcholinesterase inhibitors you can use, you use them and you try them for 2 months to see if they make a difference, and you need to like assess whether or not they have made a difference. It only confers like something like a 1 or 2 point increase in their MMSE. So it's actually not that effective, especially considering that you often give people GI side effects. So it can be worth a go. It's only symptomatic, so it doesn't mean that it's going to progress, that the disease will progress any differently. So I've written this here, which is probably bad, but typically acetylcholinesterase inhibitors will be used in the early, like mild to moderate, and then you move to memantine for the late stage. And then at the very, very late stage, you just take them off the medications because the less you have, the better. Memantine has some side effects too, but they're typically like autonomic side effects. So it can be like dizziness and myalgia. Anyway. And also has some renal impairment issues. So just consider that. All right. This guy is a 72-year-old male who presents to you, his GP, with a recent change in functioning. He has a past medical history of hypertension and atrial fibrillation. His daughter described a distinct change in his functioning a few years ago. At the time, he became abruptly less clear in his thinking, struggled to focus on more than one activity. Since then, he's had periods where he has remained the same before another slight change in functioning. So think about what that is, and then if you were treating it, what would you like? What would you do, and what in that question makes you think that it is what it is? So this is vascular dementia, or it's now called like major neurocognitive disorder due to vascular disease. Any risk factors? If there's a question, any risk factors for like vascular things? Diabetes, like high blood pressure, cholesterol problems, and they'll see a stepwise decline. So it'll be like they were fine, and then they had a they had a stroke or a funny turn. In questions, they're not going to say to you like they had a stroke and now they're unwell, because it's too obvious, I think. So they'll say like they had a funny turn, or they've been having like small stepwise declines. Yeah. Oh, and the other thing is often this can coexist with Alzheimer's disease. So it's not just, so if they're having these stepwise things, but they're also showing like decrease in that time, it's possible that is also due to like small, like micro infarcts. So if they're going to have a huge stroke that makes a big impact, or they can have like a lot of like subclinical sort of strokes. And the way that this will be found out will either be they'll have a stroke and then they'll develop dementia. And so you say like, this is a stroke, dementia in the context of having vascular disease, or they'll come with dementia, like this stepwise dementia decline, and then they'll do a brain image and they'll say like, we can see that there's been vascular stuff. So you do a CT or MRI brain, which you have to do for everyone at some stage during the course of their dementia, and preferably like early on, just to exclude other causes. So try to treat the underlying disease, which will be like, if it's like hemorrhage, if it's infarcts, it'll be antiplatelet stuff and like lifestyle modification, although they're usually like older, so that can be a bit harder to do. BP control, so I don't know, blood pressure medication. And then like if there's diabetes, you need to get the glycemic control. Essentially just try to address all of the vascular risk factors. And if they have, you can try them on, you can just give them like a trial of the cholinesterase inhibitors, because there's a possibility that they'll have like Alzheimer's disease at the same time. That's in real life. I have a feeling that probably in Monash exams, vascular dementia doesn't come up very much, but if it did, you probably would. You could just say, you just justify why you would do it. And they can have like an increased risk of falls too. So again, like it's just the risk factors. Just try to like think about the risk factors and the stepwise decline in a question. So if that's what you're seeing in a question, that's possibly vascular dementia. Okay, this guy is a 65-year-old male. He describes falling whilst gardening. On further questioning, he explains that it occurred as he bent down to see the small people playing on the plant leaves. He is sent home after x-rays that show no fractures and is given risperidone, and now he presents with severe Parkinsonism. So, yeah, maybe just think about what it is and how you're treating it. So this is like Lewy body dementia, essentially, or this is how it'll look in an exam question. So the like key features of it are like fluctuating course, and that'll be like from day to day and from minute to minute. Visual hallucinations, but they're often pleasant visual hallucinations, and they'll be of like small animals or small people, and they're called like Lilliputian or something, I don't know. But anyway, you'll know when you see the word. They'll have Parkinson's features, and there's like this distinction of like, it's a frustrating distinction, but it's something like the year, if you have onset of dementia and then you have a year and then you start to develop Parkinson features, it's Lewy body dementia. But if you have the Parkinson symptoms first and then you develop this, like Parkinson's dementia, it's a bit annoying. But I don't think it comes up much. REM sleep disturbance is really typical. Like it's one of the buzzwords used, I think, for Lewy body disease. And they have neuroleptic sensitivity, which means that if you give them an antipsychotic, they're likely to then come in with like a neuroleptic crisis. And then the memory will often present later. So these are like the symptoms that'll come first, like their attention's bad, they seem pretty out of it, but then they'll be fine. And it's because of like deposition of these Lewy bodies in the brainstem, substantia nigra, which is why it also presents as like a Parkinson's picture. So don't use antipsychotics with them. You can do this, the SPECT, to check for like decreased perfusion in the brain, and then there's not much you can do to manage it, or any of these actually. You can give them cholinesterase inhibitors, and the interesting thing is like Lewy body disease shows like a disproportionate response to cholinesterase inhibitors. So if you give someone with dementia and they improve heaps, you should start to think about like whether it could be Lewy body dementia. And then just try to stop them from falling because they're at increased risk of falls. So in this case, this guy has falls. He is seeing he's having visual hallucinations, and he has severe Parkinson's. The other thing is like they have visual or spatial impairment, so maybe it would present with some of these things plus like car crashes, and there'll be this fluctuation, but it won't be acute in the same way that delirium is acute. It'll be like over a long period, and that's where you have to get your collateral history from like family or carers or something. Okay, I think we're getting to the end. Miss G, so he's a 57-year-old male who's usually described as polite and hospitable. His family has noticed that he's becoming more irritable over the last few years. His friends are visiting less after being insulted when they visit him during previous get-togethers. He has difficulty completing a clock face on the MMSE and throws down the pen, expressing this is ridiculous before stopping up. So just go to the next slide. So this is frontotemporal dementia, or like major neurocognitive disorder due to frontotemporal lobe. So it's just atrophy of the frontal or temporal cortexes. Typically, I think the behavioural variant is more common anyway, but Monash again will probably, hopefully, use like the behavioural variant because it's more distinctive than any of the other, than the primary progressive aphasia. It affects this condition affects people in their 50s and 60s, and it does in Monash as well, and it does in real life, I think. And it's really the only one to affect people who are younger. Yeah, and they can have like, maybe one of the presentations can be like that they're really frustrated during a testing, and instead, because they don't have the ability to stop themselves, they'll get angry and they actually will like react. Oh yeah, and then to do the examination, primitive reflexes, so one of the tests on the frontal battery assessment, assessment battery, which we'll talk about in a bit, is just like you tell them not to hold you put out your hands and you say, don't hold my hands, and they just like can't stop themselves. So yeah. Yeah, so and then other things that might come, like the other ways that they could like put these in questions, I think would be like they're making inappropriate remarks to friends or family, or like particularly if it's a male, like maybe females towards females. They can be really mean to the people that they love. So the wife might come in and be like, he's been really cruel lately. They might have credit card debt or like other things, and they can also be really aggressive while they're driving because they don't have the disinhibition. So then general examination for dementia is obviously like there's a lot of different types, so it's quite broad, but you just do like a full neuro, and then things you might pick up are like impaired gait, and that can be due to things like Lewy body dementia, stroke, or normal pressure hydrocephalus, which we haven't talked about, but that would also be a differential. Bradykinesia and rigidity obviously are going to be in Lewy body and Parkinson's. Hyperreflexia and like focal signs are more likely to be a vascular picture. And then the dexterity and the 3-point command, so you would be like, that's when you say like, take this thing and fold it and put it on the ground. They might struggle with that more. And then your investigation, so you can try to address the reversible causes first. So B12 deficiency, folate, thiamine, Cushing's disease, or thyroid problems, which is why you want to have a look for those things. Urine drug screen as well. You can do a brain to rule out like a chronic subdural hemorrhage, or like METs to the brain, or normal pressure hydrocephalus as well. Yeah. Okay, and then I thought we'll just have like a quick look at so as you go further on in any of the dementias, they all begin to look a bit similar. So the most pronounced diagnostic features will be at the start, and then as they progress, they'll become more similar. So a lot of people with dementia will experience some of these symptoms. Depression should be there as well. I don't know why it's not, sorry. So the way that you go about managing these are not to use pharmacological treatments straight away. You should try and use non-pharmacological things because, and I think you might have had a lecture yesterday a bit on like intellectual disability and how to deal with that. People with dementia are actually like, you need to approach them in a similar way. So if they're doing something, it's probably because if they're acting out, it's probably because something is going on. So they might not like when they're getting like they might not want to be showered at the time that they're being made to shower. They might be in pain. They might be like a co-patient that's being mean to them or that they don't like. Or they might just feel like they're in an unfamiliar environment and be kind of scared. So try to use techniques to do that. So sometimes, or they could be bored as well. Sometimes nursing homes in particular will have like, they're not advanced care directives, but they're like advanced, you might have seen them on Psychiatry. It's like, what do you like doing? Like what makes you calm? Like who do you like to see when you're upset? What can we do? So like can get them to try or get family to do that. And then like with FARM, you just try to avoid antipsychotics, but you can start off with SSRIs, which are actually quite effective for like the behavioural side of things. Sertraline is a good one, or citalopram. Metazapine, I'm sure you've heard a lot about it, but just know that poor appetite and insomnia, you can give that to them if there's also depression present. And the low dose is more sedating. So 15 milligrams is more sedating than 30 milligrams. And then just consider like the risk benefit in terms of the adverse effects. So risperidone you can use for like agitation symptoms, but just try to avoid it in vascular dementia because it can increase their risk of cardiovascular events. And then in terms of dementia, just try to address like the legal considerations. So like early on when they still have capacity, if you can talk to them about like their powers of attorney, like creating an advanced care directive, if they want to go into like a nursing home or anything, if they don't want to, and financial issues. Functional considerations, so you might get an OT assessment of their home. You need to like inquire about their assisted daily living activities. Maybe like their risk of falls, so their house might just need to be like looked at. And then driving, whether or not you need to take away their license, or if you could do like a restricted license, or how you can review that regularly to make sure that they're not dangerous. You might want to give them like a distress necklace, or like that they can press the button on. Care stress is a really big deal. They get really burdened. So it might be worth getting some psychological support for them. You can link them in with things like Dementia Australia, which is actually like really, really helpful. And you can get respite care as well as support packages. So the government has like some different level support packages. You can get people into the home to help. Oh, and the other thing is sometimes, and it wasn't in any of my things, but people can present with dementia when their carer isn't available. So if their carer passes away, or like their husband goes away or something, that's when it becomes obvious how dependent they are on that person and that they actually have quite advanced dementia. So these are just like what I think are like your kind of like buzzwords or the different things, or like prominent features of them. The things we didn't talk about, it's just like there are other causes as well that you can just like consider. And normal pressure hydrocephalus, which you probably know the triad for, I would say. So let me talk about that. All right, so Ms. M, it's a 63-year-old, presents with concerns such as becoming more forgetful, less able to do her work as a social worker. Her husband describes her as being more irritable over the last 6 months and is less interested in spending time with her grandchildren, who she previously adored. She says she's exhausted after returning from work. On an MMSE, she scores 23 and didn't complete the serial 7s or object drawing. So, just go to the next slide. So, often, so this can be a case of like pseudo-dementia, which is essentially depression. So your DSM criteria still apply, but sometimes it's a bit harder. But they'll present with like a global memory loss that'll improve with antidepressant therapy. They'll often say, I don't know, on the MMSE, as opposed to like trying it and just not being able to do it. Yeah, that's probably it. And then there are some different scales, which we'll talk about in a minute. And also they'll self-present. So often people with dementia will lack insight to some degree about the fact that they are losing their memory, and they'll be quite frustrated about it. Whereas people with pseudo-dementia or depression will come being like, oh, I'm so forgetful. Yeah, she's irritable. Yeah, that's anhedonia. Doesn't complete the test. So there's different scales for measuring depression in like older populations. You don't really need to know them, but maybe it would just be good to like be aware of them so that you could use them. Geriatric depression scale is actually quite sensitive, so it has like an 80% sensitivity, and you can give it to people and they can do it in the waiting room of like a clinic in like 5 or 10 minutes. And if you do it every time or every like 6 months, then you might get a gauge if there's a change. Cornell is best for people with dementia, and Beck's can be used in post-stroke people. So you just need to like tailor the questions based on people. All right. Maybe just like create a table with the things if that helps you. If not, I think they're pretty like you can think your way through them anyway. Cognitive tests. So you've got the MMSE. I think it was initially created to test cognition, but particularly in psych demographics. So whereas like the mocker, and it relies a lot on your education and your language skills. So it's not necessarily it's good as a screening test, but it's not like definitive, and it can like mask the severity, or it can seem to worsen the severity for people. Mocker is a bit better because it's less like language based and doesn't depend so much on your education. The frontal battery assessment can test for frontotemporal dementia and has a few components, and we've talked about that. So I'm sure you've seen those. Frontal battery assessment. So they do things like, in what way are these two things alike? So they say like, what does a chair and a table have in common? Or like, what does a banana and an apple have in common? And they're supposed to say like, they're a fruit. And if they don't, then you can like prompt them. If they say something like how's an orange and an apple similar? And they say like, you can peel them both. You're like, yes, but they're also both a fruit. And then you'll score them 0 for that. But then for the next two things, that hopefully they can like grasp what you're trying to get them to do. Lexical fluency. So if you use the letters S, F, and B, what you get to do is you say like, in 60 seconds, I want you to say as many words starting with the letter S as you can. And then they have to say more than 9 words. But in 60 seconds, but you should probably, if you can try and use like S, F, and B, because it also is an indication of disinhibition, because our minds go to swear words, unfortunately. So Luria test. So you get them to do you say I'm going to do this thing, and then I want you to repeat it, and you get them to do that, and then you get them to do it 6 times. And if they can't do it, it marks them down. There's this tapping thing. So you say, I'm going to tap twice, and I want you to tap once. And then when I tap once, I want you to tap twice. And then the other thing you can do is say when I tap, don't tap, and vice versa. Except people really struggle with it if they have disinhibition, because they really want to tap. When you tap, they're like, oh. And then there's that thing about don't take my hand. It's cute. Okay, so quick recap. Delirium, so acute mental change, fluctuating organic cause. You can have visual hallucinations, and they're usually unpleasant. You can use the CAM score to diagnose it, and just try and manage it without antipsychotics. There's so many non-pharm things you can do, and nursing staff are amazing in terms of calming patients down without medications. Dementia, Alzheimer's accounts for 50%. It begins with short-term memory loss, and then it'll progress. Vascular, stepwise, and it'll be in the presence of cardiovascular disease. Lewy body dementia will have often pleasant visual hallucinations, and you get some Parkinsonian features later, and this pattern of fluctuation from minute to minute and from day to day. Frontotemporal personality changes, disinhibition, and you can have the progressive primary aphasia, so they can have word difficulties as well, but I don't think that will come up as much. And then there's other causes. And then in terms of pseudo-dementia, they're Monash won't say about a patient with dementia often like, oh, they feel like they're losing their memory, because then you'll be like, oh, that's dementia. So when Monash says like, oh, they feel like they're losing their memory, you're like, why did you tell me that if they have dementia? So they're often likely to have depression, and yeah, you can just use different scales to try and gauge that. And that's all, I think.